Can you all see the presentation now?
I can see it, yeah.
Excellent, good. So as I said, we're going to be covering about sepsis in pregnancy.
I'm going to log out and back in, if that's okay.
Sure,
Yeah.
no problem. I'll give
Sorry.
you a moment.
I have the same problem. Oh, now it's up. Now I can see the screen.
Sometimes it is a bit slow. Okay, so in terms of sepsis in pregnancy, as I said, we will all be familiar to some extent or other about the underlying pathophysiology and about the specific signs, symptoms, SIRS, and the systemic response and things like that. So I'm not going to go into that in detail, but we'll talk very briefly about what sepsis is, what septic shock, and the particular risk factors that you need to look out for in pregnancy or women who have recently delivered. Then we're going to discuss why is it so difficult sometimes in diagnosing sepsis in someone that is pregnant or who's recently had a baby, because obviously one of the underlying themes when we look at why women die as a result of sepsis in pregnancy or after delivery, one of the recurring themes is the fact that there's delayed diagnosis. And in part, that's because it's difficult to diagnose sepsis sometimes. As I said, we'll look at the risk factors, signs and symptoms, and the implications for mum and baby. And then we'll focus on group A sepsis, chorioamnionitis, influenza, and COVID. I mean, that's just some of it. And then there are lots of other conditions which you'll just need to read yourselves in the strategy module on, oh, it's not called strategy anymore, but anyway, the module on the college website has a lot more information. So in terms of what sepsis is, I mean, the definitions are always being updated, but in 2016, there was an agreed definition for sepsis and septic shock. But the point is, it wasn't specific to just pregnant women. So then WHO undertook a systematic review, and after expert consultation in 2017, they came up with this, that maternal sepsis is a life-threatening condition, which is defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or postpartum period. And the abortion one is really important not to forget. So not really groundbreaking, doesn't really tell us very much, but it was just an agreed definition and something which, for the purposes of audit and data collection, just makes it easy if you've got a defined standard. So why does it matter? When you look worldwide, it obviously is a leading cause of maternal morbidity and mortality. So in, oh, sorry, wrong page, sorry. No, I skipped it. So what is septic shock? Septic shock is a subset, so it's obviously the severe end of sepsis, isn't it? Where you get multi-organ involvement, dysfunction, and you're more likely to obviously die as a result of having sepsis. Septic shock is defined by having hypotension, which basically doesn't respond to adequate fluid resuscitation. So the patients then require vasopressor therapy to help them, so they'll be in ITU and things. And then having a lactate of greater than 2, and if a lactate is more than 4, that indicates severe tissue hypoxia, with the end result obviously being hypoxia, cell death, organ failure, coma, and death. All very morbid, but this is what we're trying to prevent. And as I was saying earlier, it's a leading cause of morbidity and mortality. So 8% risk of mortality in high-income countries, which is significantly higher in lower-income countries. So about 25 to 40% of maternal deaths have infection and sepsis as a contributing factor. And when we look at the risks to baby, there's increased risks of miscarriage, stillbirth, preterm birth. And just to put it into perspective, up to a quarter of cases of stillbirth in high-income countries can be associated with infection. A lot of that is to do with preterm SROM, chorioamnionitis, and then that's higher in low-income countries, up to 50%. And some of that is associated with abortions, especially later abortions. So it's a real, it's obviously important, not only in the UK, but worldwide as well. Now, have we all heard of the Embrace report?
Yes.
Yep.
Yeah.
Can anyone just summarize for me what is the Embrace report? Or what do we know about it?
Isn't it sort of then they systematically review all the maternal deaths over a certain period of time and look about like what the causes were or what sort of contributing factors were to those deaths?
Yes, exactly. So before a triennial report used to be published, but then it was felt that that's too long. It then takes too long to find out any themes, to come up with lessons and recommendations. So then it was changed to look at deaths in a year. But then even then it takes about 18 months or so to obviously collect and analyse all the information. So there is still a lag, but yes, Veronica, you're right. It's looking at all maternal deaths in a set period. So this is the most recent Embrace report. I think the next report is actually due later on this year, quite soon in November. But the deaths are all split into direct deaths and indirect deaths. The direct deaths obviously relating to pregnancy-related causes of deaths, whereas indirect she just happened to be pregnant, but then she's died as a result of whatever the disease is. And if you have a look in the period from 2016 to 18, sepsis was 1, 2, 3, 4, 5, fifth leading cause of maternal death, and 31 women died during that period, with 23 of those being pregnant or within 6 weeks of having delivered, and 8 were late deaths. So late deaths are from 6 weeks up till a year after having had baby. So a maternal mortality rate of 0.95 per 100,000 maternities. But I mean, it's interesting to see, and it's always chopping and changing, but sepsis is always one of the ones, you know, it's definitely in the top 5 usually. So it is important. Then when they looked further and broke it down further, well, why are women dying? They break it down into genital tract sepsis and those after cesarean section. So these are the direct causes of death. So you can see the bugs involved: group A strep, E. coli causing chorioamnionitis, and then unknown in a small proportion of women. And then the indirect causes are these ones here. So she just happened to be pregnant but died as a result of either influenza, TB, pneumonia. So these are other things to obviously be aware of as well. But okay, so why is it so difficult to diagnose sepsis in pregnancy? And I know some of you might think, well, we diagnose every other woman as being septic because obviously, you know, someone mounts a temperature, the white cells are a bit high. It seems that when you're in the world of maternity, in obstetrics, every other patient is septic. And this is a comment that we get from lots of, especially GP trainees or foundation trainees who perhaps don't quite understand the physiological changes and things. But obviously we've got to have a very low threshold for sepsis. So yes, we probably do overdiagnose. But what parameters do you think makes it difficult for us to say whether or not someone is septic? So think about the physiological changes that may happen.
Well, for one thing, all pregnant women have high white cells anyway, so it's difficult to know when that's significant.
So what might be normal then, Joe?
We might draw a line at 20.
Yeah.
Ish.
Yeah, no, I agree, about 20-ish. There's no hard and fast rules about this, but you've got to try and have a normal-ish parameter. So up to 20, agree. Anything beyond that, you would wonder if there's something going on. Yeah. Remember, it's a neutrophilia, isn't it? So the neutrophils are higher in pregnancy anyway. What else?
Generally, the blood pressure tends to get lower in pregnancy.
It does, yeah.
If you think about labour as well, like, you know, they're going to be hot from pushing a lot, their heart rate's going to
Yep. So the heart rate's high in pregnancy anyway, isn't it? And then obviously it's like running a marathon, so they say. So their pulse will be higher still. Yeah.
And chorioamnionitis is more seen as an infection around baby and not necessarily will result in a pyrexia earlier on in the woman.
Yep, absolutely.
Reluctance to image or inability to do certain imaging?
Yeah, definitely. And that's one of the, we'll talk about some case vignettes as well from some of these cases, just to bring these messages home. But there is always a lot of reluctance, even in hospital. Obviously, there will always be that reluctance on the patient's part, but even GPs, you know, radiographers, all the rest of it. So we need to be never subject anyone to a test unnecessarily 2. If they need to have a test, then make sure you've had a good discussion with the patient. But yes, definitely that's a recurring theme, that there is a delay in diagnostic treatment, diagnostic tests.
Even
the next,
if the observations are off, say in labor with the heart rate rising, there are other things that could be going on, such as response to pain or uterine rupture, scar adhesions. So maybe the other differentials take over and sepsis gets lost.
Yeah, no, it's very true, because there is a lot to consider, isn't there, Vinod? And sometimes when you're potentially less experienced, it may be easy to forget about it. So, for example, if you're faced with someone that's a previous section, so the first thing you're going, and someone's got a raised pulse, the first thing you're going to start thinking about, oh, could there be a uterine rupture, or is there a dehiscence occurring? So yes, it's very easy to get sidetracked, because remember, none of these patients are generally just one. There's usually more than one thing going on, and there's more than one diagnosis that you need to consider. Yes, that's very true. So this is a very busy slide. It's from one of the TOG articles. I've got the reference, well, the reference is there anyway, but there are links at the end of the presentation. I'll share the presentation with you. But this talks about all the physiological changes in pregnancy that you can see on the left-hand side, and the overlap that you get with sepsis. So then hopefully it can help you to begin to understand how some of the normal physiological changes really does make it difficult and makes everything a little bit grey. It's not so black and white compared to someone that's not pregnant. So, someone that might be tachycardic because they're pregnant, how much is a normal rise for them or not? So now we've started to record patients' pulses at their booking appointment, whereas before we never used to. So we've never known before recently really what was normal for a patient, what wasn't. So it's always useful to go back and look at the booking appointment, not only to look at their blood pressure, what's normal for this patient, but what would be a normal pulse. So that's that can be very useful as well. Even the respiratory changes. So we know that women get a respiratory alkalosis in pregnancy, don't they? And sometimes that just means when you've got a blood gas, it can make it a little bit more difficult to interpret it as well. So it's just being aware of all these potential changes. I would say this is a useful slide for anyone that's not done part 1 yet either, just to kind of brush up on your physiological changes in pregnancy, because it's something that would be very easy for them to put into the part 1 exam. Any questions or comments about that? Fine. So I think Vinod has already kind of alluded to this, but what can be your other causes? So you've got someone that's in labour and she's got a pyrexia or she's got a tachycardia, and we've already mentioned some of the things, but what might be going on? So what might be causing that pyrexia?
Prostaglandin use?
It can be, yes. Any medication, well, not medication as such, but epidurals can also cause a bit of a pyrexia as well. Obviously, the longer their labour, not necessarily because they're brewing an infection, but just the work of labour. Somebody did mention it before, and this is going to sound very basic, but obviously if your room's a bit warmer, then it's going to be, you can push mum's temperature up a bit as well. What about a tachycardia?
Dehydration.
Yep, absolutely.
Anemia.
Yes.
Pain,
Yep.
anxiety.
Yes. Great. Now, in terms of the dehydration and medication can, yes, definitely. So there are lots of things. There are lots of things. So you have to be thinking about all of this. Is there any other reason why the patient is tachycardic? In terms of dehydration, it's quite interesting, isn't it? Have you ever thought about how much patients drink or don't drink in labour? So we've been monitoring patients using EASE when they're using oxytocin for quite some time now. I'm sure, do other units do the same thing?
It's not as strict at Wexham as it was at Reading.
Okay.
They definitely don't really at all in Oxford.
Right. It's really interesting because To be fair, we never used to. Then we had a case of a baby having really low sodium and having seizures. And so we've been monitoring it for, when I say a while, probably a year or so. But it's really interesting because we are now finding quite a few number of women have low sodiums. And sometimes that means baby has low sodium, but they don't all go on to fit. So it's just something that we're looking at better. I'm sidetracking a little bit, but this could be an interesting project to do in your units. But to look at the fluid hydration of women in labour, or even their diet in labour, because it's interesting, the amount of fluid that some women do drink or don't drink, and that can obviously affect their pulse and things like that. So it's just, we're doing this at Reading if anybody wants to get involved with it. It's quite an interesting project to think about. Right, now next thing is what are the risk factors for sepsis in pregnancy? Just shout them out.
Prolonged storm.
Yeah.
Prolonged labour.
Yep.
Instrumental delivery.
Yes.
Multiple
Comorbidities such as
examinations.
anemia.
I didn't hear those.
Sorry, I said multiple vaginal examinations.
So yes and no. I haven't ever found anything specifically relating to that to say what the increased risk is after X number of examinations. But yeah, it makes sense. It makes sense, doesn't it, that you would want to reduce the number of VEs that you do if someone has ruptured their membranes. But I know at Reading, for example, when term women present with a SHROM, we will do a VE on these patients, because then we invite them back at 18 hours for a prostin if they're not favourable, and we don't see an increased incidence of chorioamnionitis and infection. So yes, by all means, keep your examinations to a minimum, but obviously just do them when needed. But whether or not it definitely increases infection, I think the jury's out a little bit on that one. So just think about your patient in general. What is it about the patient that will increase her risk of sepsis?
Being pregnant increases the risk of UTIs.
Yeah, so that could be, yes, so if you don't treat a UTI, and yes, it can definitely lead to sepsis. But what is it about your patient? Someone sitting in front of you.
She's diabetic.
Diabetic, yeah.
High BMI.
Yes.
Isn't pregnancy alone in itself an increased risk factor for sepsis?
The
way that your immune system changes.
I guess so, because you're relatively immunocompromised. But I think nature probably has got the right balance. Otherwise, because you don't want to attack this developing fetus, do you, immunologically? But then again, you don't want to catch every bug and things going. So I don't think it's just pregnancy per se. I think it's going to be pregnancy with additional risk factors. So these are common risk factors identified by these inquiries and things. And I think we've covered most of them. So just think about your patient being diabetic, obese, as you said, Ebbs, immunocompromised, but it's not just pregnancy, having something else on top. So perhaps they're on steroids for some other reason. Anemia we mentioned, so that's why it's really important to make sure you treat someone with iron replacement if they are anemic. Some of these bugs, we didn't mention amniocentesis or other invasive procedures. So don't forget about early pregnancy things as well. Having a cervical cerclage, we said SHROM. And BAME. Oh God, I hate the term BAME, and I used it. But Black and Asian minority ethnic groups, they are at increased risk. Now, is that because they're less likely to access healthcare? Perhaps they don't speak English as their first language, or there is obviously something more than just that. But they are definitely a group who are at risk.
Ms. Johan, can I just ask about the GBS one? Because like when women are known GBS, when we're counselling them about antibiotics,
Yes.
I mean, it doesn't seem to be a uniform that people are counselling them to antibiotics in terms of to reduce the maternal infection. It's normally about the babies. So like,
that's very true.
Yeah, surely it's normal commensal. Surely it's a fetal risk, but not a maternal risk.
I guess this probably goes in hand with a prolonged SHROM. I'm guessing, because you're right, on its own, why should it cause an infection? But then if you've got a prolonged SHROM, maybe it's the reversed effects of chorioamnionitis or something. I'm not quite sure on that front.
It was interesting. I was reading an article the other day about causative agents of tube ovarian abscess, and group B strep was one of them.
Was it really? Where
Yeah.
was that, Bibs?
It was in TOG.
Okay. Perhaps you could share that with us next time, Ebs.
Sure.
Okay, thank you for that. And what are the signs and symptoms that we worry about with sepsis? So what symptoms might you worry about or inquire about from the patient? Just do a head-to-toe approach.
Dysuria, abdo pain, obviously, like not just contractions,
Yeah.
fever, shortness of breath, cough, rash.
Nausea, vomiting, sweats.
Mm-hmm.
Confusion, drowsiness.
Yeah. Headache, yes, no, absolutely. So, I mean, this is all stuff that you know anyway, but it's just trying to remember, be systematic. As I say, head-to-toe approach, try not to leave out any of the symptoms. Ask about vaginal discharge as well. Sometimes lots of women may not realise that they've ruptured their membranes, even if they are multiple. So it's really important to ask that. Sore throat, really important for group A strep as well. And then, yeah, I think you guys you covered the rest of that. Now, in terms of diagnosis, we've all come across the MAUs, MUs, MOs, whatever you want to call it, yeah? So it obviously doesn't make sense to use just generic observation charts or however you record things in your units to diagnose sepsis. So that's why this modified obstetric early warning scores was introduced many, many years ago. But even then, there's no national agreed MAUs chart. Which seems a bit bizarre considering pregnant women are all pregnant women. So I think this kind of adds to a lot of confusion, especially when we move around from unit to unit. Different places seem to record it differently and you might interpret things differently. And actually the sensitivity and the specificity isn't particularly great, but I think we've kind of discussed that already because sepsis can be, it's not as clear cut in someone that's not pregnant because of the physiological changes that we see in pregnancy. And the other thing is it's very easy to, dutifully document these observations on the chart, but it's not just about recording these observations. And this isn't so much for you guys, I guess it's for the nursing staff or the midwifery staff who are making these observations, but also there needs to be a trigger, a certain level where it then triggers a response and review. And again, one of the themes that's come out time and time again, and what's really quite sad about these reports, and I would really encourage you to read the reports, they're all available online, is we're very good at documenting and writing things, but we're not very good at identifying when someone's becoming sick and then calling for help, and if you can't get help, escalating for help. And this is where a lot of our skills and drills and prompt and things like that comes into it, because it seems simple. When we read some of the case vignettes, you'll be horrified and think, dear God, what were these people doing? But these people, these obstetricians, these midwives, these nurses could have been us in that same position. So the point is, always have a good look at the observation chart, but don't just look at any single parameter. Look at them all together and look at what the trend is. And don't just ignore someone. So at Reading, for example, our MUSE chart now incorporates a raised temperature where it didn't before. And if you've got a temperature of more than 38, it gives you a score of 3. Then all of a sudden, someone will end up with a MAUS score of 7. So first of all, it might seem quite alarming. You think, oh gosh, it's a MAUS score of 7. And then you think, well, she's got a 3 for a temperature. So actually it's only a MAUS score of 4. So you might be a bit less relaxed. I don't know. I've seen it happen. But the point is, don't be dismissive. Look at the whole situation, the whole patient, their risk factors and things, and do take it seriously. So since this has been introduced, I think we have got a lot better at diagnosing sepsis. Again, be wary of patients who are on other wards, not in maternity wards, because they probably won't be using this. So it's really important to, educate people, educate other specialties and things, or maybe even in, telling them the parameters that we would be worried about. Any questions or comments so far? Good. So this summary just this slide, sorry, just summarises the sepsis 6. We don't need to dwell on it too much because I'm sure we're all familiar with it. But it seems so logical, doesn't it, that you know, 6 in, 6 out. This having this framework to work along with. But actually, before 2001, we didn't really have this, and everyone seemed to be doing something differently. And even we're still not great at doing all of this in a timely manner, but I think there's a lot more awareness now about this, and it really does make a difference, and it does save lives. So it's just, I know you guys know this already. Very quickly then, this slide just summarises all the different sources of infection, which we've kind of thought about already when we spoke about the different symptoms that you would ask a patient. But you know, a lot of things to think about. So it's not just pregnancy specific things, but other things which could be causing infection. And these are, you know, if the patient became very unwell and died, these would be what would be the indirect causes of death. And in someone that's been recently delivered, don't forget about mastitis. So always ask about any breast symptoms, always examine their breasts as well. And don't forget about regional anesthesia and checking for their backs. And if you're ever worried, then obviously escalating to the anaesthetist. Now, we've already spoken about some of the bugs which are involved in sepsis. So we've spoken about group A strep, but E. coli is up there actually. And I remember at a recent perinatal M&M we had a couple of months ago, I think, there were a couple of babies that had been infected with E. coli as well. So I don't know, it seems to be making a bit of a comeback, but it's something to be aware of. Always check the sensitivities for any cultures, which a lot of the time actually we don't really get culture results back, do we? But when we do, just make sure that the patient's on the right antibiotics, which are sensitive to that bug. Any questions, comments?
Why does being a primate make you more susceptible?
So where's that risk factors being a primate? Good question. So this is, I mean, I've just lifted this from the Embrace report. So, I mean, primates, again, I don't know if it's partly the SHROM side of things. Maybe perhaps they don't realise. Think about the number of patients who tend to present with a prolonged SHROM. I mean, you can't say that they're all primates or not, but that might be partly why primates are up there.
And probably because we don't know what their GBS status is yet.
Oh, yeah, good point.
Maybe they might tend to have longer labours, I don't know.
Very true. Good thinking, guys. So I was just reading my notes as well. Group A strep apparently is associated more with early pregnancy and then peripartum causes of sepsis, whereas coliforms are associated with second trimester ascending infections, so things like UTI, pyelonephritis. I guess that kind of makes sense as well. Okay. But yeah, this is true. A lot of the time we have no lab confirmed diagnosis, which is always a little bit frustrating. Okay, so I'll give you a moment just to, these were 2 cases from, I think it's from the most recent Embrace report, which just reiterates the importance of asking the right questions and referring them up quite in a timely manner. I'll give you, actually, I think I'll just read it for you, but you guys can read at the same time. So on the left one, so a woman went to her GP in the first trimester with a sore throat. She had lymphadenopathy, but no other assessment was made. She then presented to gynae department 24 hours later with a DNV and feeling unwell, found to be hypotensive and tachycardic. She was reviewed by a junior doctor 3 hours after admission, who didn't recognise the seriousness of her condition. The obstetric registrar then reviewed 6 hours later, gave her some antibiotics, which weren't given for over an hour. And when everyone finally realised how sick she was and she was transferred to ITU, she then died from overwhelming group A sepsis a short time after she was delivered. Now, you look at that and you think that could be any patient, couldn't it? So if you talk about this first case, you know, how many people do we come across with a sore throat? And it's very easy to be dismissive about someone with a sore throat. But the point is, when they're pregnant with a sore throat, the first thing you should think about is group A strep. So you should definitely take a throat swab. Obviously examine them. So by no other assessment, I mean, this is all the information that they give. So I don't know if she was ever examined or not. Now, I'm not saying that the GP had to refer her instantly up to DAU or, you know, to the acute gynae clinic because of a sore throat in the first trimester, but just having a bit more of a think, could this be group A strep, taking a throat swab, maybe giving her antibiotics, could that have made a difference? I don't know. Why does she develop diarrhea and vomiting? It's very easy then to think of other things. Could she have got a bug? So anyone that she's been unwell with, think about any food takeaways, things like that. But it's just trying to piece everything together. If she's hypotensive, well, perhaps that was a bit normal for her. But remember, what did we say about being hypotensive? So if your blood pressure, I think it was less than 65 millimeters of mercury, and you're not able to maintain it above that, then that shows that she's seriously unwell. And obviously with the tachycardia, she's compensating for it. But then again, you know, there are lots of reasons, as we discussed, for being tachycardic as well. The whole review in a timely manner, not recognizing how sick she was, therefore lack of recognition, lack of escalation. Antibiotics were prescribed, that's great, but you know, not given in a timely manner, you know, ideally should have been given within that first hour. So again, if you prescribe something, make sure that it is actually given to the patient. It's very, you know, it's not just about writing up on the drug chart, make sure that it's administered as well. So that's very sad. And you just think, that makes me sad. You just think that could have been, not judging, not to say that we would be any better, but you can see how simple things, it just is this whole Swiss cheese problem, isn't it? All these small errors, delays, it all adds up. 2 hours later, another patient, 2 hours after a delivery, a woman became unwell on the postnatal ward, feeling very faint. Her oxygen saturation was 65%. I mean, that's quite dramatic, really. She was reviewed by junior staff, found to be shocked with some moderate bleeding. Temperature was never measured. Diagnosed to have with a hemorrhage, treated with fluids, failed to improve, taken to theatre, and she had a cardiac arrest. She had a laparotomy hysterectomy, but resuscitation failed, and the post-mortem found an extensive blistering skin rash, swollen labia, DIC, and group A strep. Very alarming. I just think, gosh, so much to say about that, but I'll let all of that sink in. But again, this could have been any of us dealing with patients like this. But the point that the reason why I've chosen these two cases is to show group A strep is an awful bug. I don't know if has anyone ever had any experience with group A strep with any patients?
I think there was one maybe a couple of years ago who went to ICU, but I remember like she stayed on ICU for quite a while, and when they tried to go in and operate, the tissue was just so friable. And
it's a mess. Yeah. It's an awful bug. I mean, it's a normal bug, isn't it? We get it in our throats and things. Gives us all a really sore throat, but it's a horrible bug. So these two cases, as I said, highlight early first trimester or peripartum. And if you've got someone with identified group A strep, it should be an emergency situation. You have to get these patients in, get them treated in a timely manner, early senior review, early escalation, get outreach, ITU input as well, because the sooner you get on top of it, the better. Any comments about these cases?
Can I just ask, is group A strep a communicable disease? Because I'm sure we had someone on the ward not long ago, and the people were asking if they'd referred to the...
Yes, it is. It is. Now, single cases on their own, so you always have to barrier nurse them. So they have to go into a side room, barrier nurse them, gloves, apron, all that kind of stuff, good hand washing. So they have to be isolated. But single cases, you do need to report them, but probably no action is taken. But if there's a cluster, so in Reading over the last couple of years, we did have a cluster of cases. I think we had one in gynae, so first trimester, and then a couple were peripartum, and we all had to take, this was actually just leading up to COVID. It was the year leading up to COVID, and we all had to wear, or we were supposed to wear, aprons for even VEs, protect our eyes, and we had to wear gloves. I mean, a lot of that stuff you would wear gloves anyway, but you know, the extra precaution of gloves, taking everything off. good hand washing. So we had to do that, and it was for a year after the third case was identified, but then COVID happened and then it all went to the next level. But yes, it has to be reported, and if there seems to be a cluster, they will even try and contact trace and see the people involved, because obviously it can be transmitted from hospital staff, can't it? So it can be in the community, within households, but from asymptomatic members of staff. So if you've got a really sore throat, you'd even think twice about, oh, could this be group A strep? If you're very unwell, I would even say make sure you get seen, swabbed and treated. But yeah, yes, it is one of those infections that you need to report. Anything else? So group A strep. So back in 2006 to 2008, it was the leading cause of direct maternal deaths. There was a surge basically of community-acquired group A strep. So it was a leading cause that was identified then. So measures were put in place, and it's definitely come down since then, but it seems to be making a bit of a resurgence. It's often insidious, but it can progress very rapidly. Someone can go downhill literally within hours. So you must make sure it's treated aggressively. In the community, 5 to 30% are asymptomatic carriers, usually on the skin or their throat. And usually maternal sepsis is preceded by sore throat or an URTI. So what's really important is to ask about family members, especially if they've got snotty, grotty kids at nursery and things, because that would make you think about group A strep sooner, as opposed to if you don't ask. And as I said, it can be hospital acquired, and there can be outbreaks within hospital as well. Who's at risk for group A strep? So we've already said about the sore throat, and you've got upper respiratory tract infection.
Well, I think, like you just said, anyone living with children who are going to school. Yeah. Or anyone of school age.
Yeah. So what I've got here, and actually, who brought up the thing about VEs as well? Actually, it is on here. Frequent VEs. Can't remember where I've got this from. It'll be from the TOG article or somewhere, I think. But yeah, these are all the risk factors: cesarean section, prolonged labour, frequent VEs, traumatic delivery, retained products, poor personal hygiene. So again, another really important thing, which I don't know how many of you have conducted many instrumental deliveries, but when you're debriefing these patients, it's really important to talk to them about perineal hygiene and things. And one of the things that we should talk about is making sure they wash their hands before and after they go to the loo. So you don't want them to have just cleaned their snotty kid's nose, or they've just blown their nose and they automatically, sat on the loo, whatever. But, good hygiene. So changing pads regularly, washing hands before and after they go to the loo. Really, really important. Signs, symptoms, all the, regular ones that you would expect. I'll give you a moment to read that. And then in terms of preventing group A strep, kind of what I've said already, just really good personal hygiene, washing their hands, especially if they're surrounded by people that are a little bit unwell, and giving antibiotics in the right clinical scenarios. So anyone going for termination, they're given antibiotics which they take before, or sometimes they might be given PR metronidazole or something like that afterwards. Treating a preterm or prolonged SROM, that's why you give antibiotics at section or with a third or fourth degree repair. We've had the anode trial recently, haven't we? I don't know how many of you might have been involved in that, but that was probably about 2 or 3 years ago, and I know Reading was definitely involved in recruiting patients, and they looked at the incidence of infection, so perineal infection after an instrumental delivery, and whether or not it was reduced by administering antibiotics an hour after, within an hour of having the instrumental delivery, and it has shown that it reduces the risk of infection. Therefore, I know we're definitely doing it in Reading. Are other trusts doing it as well? So giving antibiotics within the first hour of an instrumental delivery?
Oxford is.
Wexham is.
Yeah, perfect. So that's all come about from the anode trial. Any questions, comments about Group A strep? I think if you take away anything from this about Group A strep, just be scared. It's a horrible bug. And remember, bearing in mind that these women, pregnant women, are generally young, fit women. They will tolerate pregnancy well. They will tolerate the changes of pregnancy and then the early changes of or early stages of infection and even sepsis very well. But then they can fall off their perch very quickly, become very sick. So just always be paranoid even of Group A strep. So think about sore throat, foul, vaginal discharge. Get the right people involved early.
Mr. Allen, am I right in thinking that the peripartum Group A strep then is less particularly associated with the sore throat picture? The peripartum Group A strep is more of a genitourinary tract infection.
Possibly. I'm just trying to think. I guess the earlier ones, maybe it's more associated with terminations or definitely with illegal abortions and terminations in lower income countries. That's probably where that's arising from. So it's probably more skin, therefore vaginal sources of infection as opposed to sore throat. But, as we saw in that first case, it was a sore throat.
Yeah, cool.
So yeah, first trimester and peripartum, think of Group A strep. Okay. So choriamnionitis, another relatively common, but how many really true cases of choriamnionitis do we see? So I don't know how many yet have come across really stinky, really offensive liquor where that's true choriamnionitis. But a lot of the time it's just suspected and you can't really prove it one way or the other, but it's kind of putting all the pieces together. Occurs in about 1% of live births, but the incidence is increased if there's pre-labor rupture of membranes, up to about 30%. 96% of cases are ascending infection, and the rest of the time is because of septicemia from infection from mum. And usually there's more than one bug involved, but the commonest ones are E. coli and Group B strep. And the Group B strep, I can't remember who mentioned it earlier on, but that's why we would then give mum antibiotics to try and reduce the risk to baby. I think we've covered most of these risk factors already, actually. So let's see. Prolonged SROM, prolonged labour, multiple VEs with membranes ruptured, being a primate, Group B strep, alcohol tobacco use. I guess that's partly compromising your immunity on top of being pregnant. Having meconium, actually, yeah, that's a really important one that we haven't mentioned at all yet. Meconium is awful, it's horrible. Not only can it increase your risk of choriamnionitis, but it can increase risks to mum as well. So if there is MEC and significant MEC, make sure you clean mums, give a bit of a wash out, clean the gutters and things well if you're at section, for example, because it can be very irritable, I guess. Can cause infection. So yeah, you definitely need to think about meconium. Internal monitoring, I guess they're probably thinking of an FSC, which you would only use obviously if it was absolutely necessary, so a raised BMI, for example. I don't know why epidural's there. Maybe it might relate back to what Eb said before, prolonged labour. Maybe they're more likely to end up with an epidural. Therefore, prolonged labour, prolonged SROM maybe increases your risk of choriamnionitis. So again, a lot of overlap, really, a lot of the stuff that we've covered already. Now, choriamnionitis is, you can suspect it, but it can be very difficult to manage because you may well have a case where you've got a fetal tachycardia, but mum's not pyrexial yet, as Vinod said. And maybe the labour's progressing well. So it does become very difficult to know sometimes what the right thing is to do. Now, obviously, you don't want to leave baby in an environment of either raised pyrexia, so babies don't like to be cooked. So you don't want to leave them in that environment for too long. But what I would say is, if the patient's in later stages of labour or the labour's definitely progressing well, then it's probably okay. So give the antibiotics and things to continue with labour. But it's almost easier if they're early in labour or if mum's got a pyrexia, and even easier still if there's meconium just call it a day and deliver that baby sooner rather than later. So we'll do a section at that point. But it does get a little bit tricky when it comes to managing these patients. Any comments or anything anybody wants to ask? So what might be the implications for mum and baby then with chorioamnionitis? So you've identified it, then what else are you thinking about to be conscious of with mum and baby?
With longer hospital stay might be some separation between mum and baby in the early stays.
NICU admissions.
Yeah.
Neonatal sepsis.
Yeah, definitely.
Death.
Death, absolutely. Yes, sepsis can cause death, can't it? So in terms of mum, I mean, it goes without saying. So like I said, early in labour or labour's potentially not progressing, or you just have a lower threshold to bail out, so more likely to end up with a section. What other infections can it cause? An endometritis, wound infection, a pelvic abscess. Abscess, I have to say, I've not come across. But when someone presents to you after they've gone home and come back with possible endometritis, just think, when did you shrom? Was there a prolonged shrom? Then it makes you think more likely that this could be an endometritis picture if there was a prolonged shrom, for example, or pyrexia in labour. More likely to bleed. Excuse me. So if there's an infected, uterus with infected contents, might be more likely to be atonic, more likely to bleed, and then obviously the risks of sepsis, DIC, all that kind of stuff. And then for baby, we said sepsis, death. Remember, they can be hypoxic, and they can develop pneumonia or have a bleed as well. It's a very difficult one sometimes to diagnose and, as I say, manage. And the problem is, I think, we're all fixated on hypoxia in labour, aren't we? So we'll be looking at a CTG and we'll be thinking about what are the physiological changes that we expect. There'll be raising baseline, reduced variability, or variable D cells and things. And then we're all thinking hypoxia, but just don't forget about infection, because infection doesn't necessarily mean a hypoxic baby. You can be hypoxic and infected, in which case it's worse for the baby. But just try and think about infection. So if there's just a tachycardia for baby, that should be the first thing that you think about. Now, the next slide's a little bit busy. Again, from the Embrace report, just talking about extremely preterm, pre-labour rupture of membranes. So before viability, so small proportion, obviously those of you working in Oxford, you're going to see a lot more of these patients, aren't you? So it occurs in about 0.7% of pregnancies. If it's going to happen, it usually happens in the first few days of her having shrommed. So that's why we would always keep them in hospital, but they're also more likely to then deliver. So we'll keep them in hospital usually for around 48 hours, give them antibiotics, and then antibiotics to complete when they do go home. If there are signs of sepsis in mum, then remember, mum's always the primary concern. So you would obviously give her antibiotics and things, but then you need to talk about potential delivery, maybe offering termination to the patient. So it's a very challenging situation when this does happen. I think that's probably as much as we need to say about that at this stage. When it comes to ST3-5, definitely ST6-7, then you'll go into this in a lot more detail, because then you need to think about mode of delivery and all that kind of stuff. But the main thing is these very early preterm shroms don't always have a very good prognosis. You need to treat with antibiotics, need to think about delivery, and with delivery, whether or not you terminate the pregnancy. But obviously, viability is getting earlier and earlier, isn't it? So I think we're referring up to Oxford. Is it 22 plus 5? Something like that. So it's getting earlier and earlier. But it's just having that conversation. Obviously, you guys won't be, but further down the line, thinking about what's going to be best for mum and baby. So we've got another case, again relating to, I think, chorioamnionitis. So a patient in the second trimester presented with vomiting and preterm rupture of her membranes, found to be septic with chorioamnionitis, and which had caused an IUD. Sepsis rebundle was promptly applied, had blood cultures, discussed with microbiology. The antibiotics were given within an hour. Despite fluid resuscitation, she was for her hypertension, she didn't get any better. They then performed a hysterotomy to remove the baby. And then after 2 days of intensive care, she made a full recovery, and she actually went home. So I thought I'd better put in a good case as well, because it's not all doom and gloom. But this is the point, is when we do it right, patients do survive. So the main point of this is about source control and trying to identify. Here it's quite obvious, isn't it? You've got a dead baby, and that's going to be the cause of this. Well, was there an infection first that caused the IUD, or has the IUD happened and it's caused the infection? That will be a difficult one to say, but it makes sense that there is a dead baby there, and expediting that delivery should make mum better. So, you know, giving timely antibiotics, all this kind of stuff. Yes, she went to ITU, but she managed to recover and she went home as well. So when we do things right, you can have a good outcome. Any questions or comments?
Joanne, I just wanted to ask a question. When the pregnancy is pre-viability and there's no rupture of membranes, but chorioamnionitis is suspected, is it common to do an amniocentesis to make a diagnosis and do culture and sensitivity, or no? Because I've seen a case referred from Oxford for termination in at Stoke Mandeville, but that was something that was done in Oxford. She got the diagnosis from there, and then she came for the termination to Stoke Mandeville. But I've never seen it being done at Wrexham Park or at Stoke Mandeville.
I have to say, I've never come across that, because one, so she's not shrommed. So what would lead them to think that there even was a chorioamnionitis? I mean, yes, you will read it in text and things that you can do an amniocentesis to look for infection. But then again, it can introduce infection as well, can't it? I've never seen it being done, Vinod. So I really don't know. There must have been a bit more to it, potentially.
Yes, sorry, I don't know the ins and outs of the case.
Yeah, that sounds rather unusual. Typically, you'd expect there to have been a SROM or a PROM, because with an intact membranes, obviously you can get infection, because it's probably going to be an ascending infection. Perhaps it was a UTI or something like that. But remember what we said, normally it's from a SROM and less likely to be the other way around, from a mum having a septicemia and then causing chorioamnionitis. That's a very unusual case.
There's one case that I saw in Oxford where they actually did an amnio to check if she had chorio. She came in quite septic, feeling unwell, so they weren't sure if she had meningitis or if they thought it was coming from the fetus and it was a chorio. So they actually ended up doing an amnio to check for the inflammatory markers to rule out. But that's the only time I've seen it.
Yeah. So like I say, you will read about it. I've not seen it in practice. Maybe it's one of these things in the bigger tertiary centres potentially that they will do. But like I say, it's weighing up the risk and the balance, isn't it? Because you can also introduce infection that way as well. I think, in these cases, they will be few and far between. Then it would be worth obviously having a chat with one of the tertiary centres and seeing what they would advise. Thank you for that. Very quickly then, because I know we are overrunning. Good job that we've got a break tabled in. But I thought we should talk about COVID. Not going to say a huge amount about COVID. Obviously, being pregnant doesn't increase your risk of getting COVID, but if you were to get COVID, you're more likely to become sicker. And hopefully you guys are aware this week there's been a real drive nationally from the government at every level to try and encourage women to get vaccinated to get the COVID vaccination. And they're suggesting, getting vaccinated at any stage of pregnancy is fine, but ideally in the later stages of pregnancy, so they've got higher protection from the vaccine, simply because we know that women in their third trimester are more likely to become sicker with COVID. And I think I heard the statistic that at the moment 1 in 6 patients who are receiving ECMO are either pregnant or recently delivered. Well, they would have been delivered actually by that stage. If they're that sick, they would have been delivered. But I found that quite astounding that 1 in 6 women have been recently pregnant. So it's really, really important. So whenever you see a patient in antenatal clinic, DAU, MAU, whatever it is in your assessment units, really important to have that conversation with them and say that it is recommended to take the vaccine, because it's safer to have the vaccine as opposed to risk becoming very unwell with COVID. The commonest symptoms, more likely to present with, less likely to have the typical symptoms of muscle aches and fevers. I've had women that have just had abdominal pain, a bit of diarrhea, vomiting. You might think of other causes like gastroenteritis, but you don't lose anything by doing a COVID swab. I'm sure you guys have all got your own stories. Any unusual symptoms that anybody wants to share with us that they've come across?
There was one person who, it was lucky because recently my housemate at the time had COVID, and she'd had this blistering and swelling of her toes and a rash. And I saw someone in DAU, and she had like a similar rash, and I was like, "Oh, let's do a COVID test."
Oh wow! Okay. And you said that's COVID. Was it COVID then?
Yeah, it was.
Amazing, Ebs. Excellent job. Well, they do talk about these rashes on the toes, which is very odd and specific. I think at one time they were talking about 5 different types of rash. I don't know what happened to that. It's obviously not an official symptom, but yes, you do get lots of weird and wonderful things, don't you, with COVID? So, as I said, severe illness more likely later pregnancy. There is a lot of debate. It will vary in every hospital. Where's the best place to care for these patients? We very much feel that it's a medical issue. They should be on medical wards, but you need to have joined up care between, the medics, obstetricians, have regular review, have MDT discussions about these patients. Risk factors we know, so being older, so more than 35, BMI surprisingly more than 25. I would have thought it would be higher than that. Any underlying comorbidities are hypertension, diabetes, increased deprivation, and again, being Black, Asian, or minority ethnic backgrounds. So those are the type of women who tend to get sicker and need to have more help. A bit more information. So Embrace did a special type of review just between March and May last year to try and look at the trends and to come up with learning and recommendations related to COVID. And in that time, they found that 16 women had died from either COVID or I don't know why they've grouped in here mental health or domestic violence related causes. But anyway, 10 out of those 16 were COVID. Oh, I think, sorry, looking at all maternal deaths in this March to May timeframe. Sorry, that was what they looked at.
As a lockdown effect?
Yes, sorry, yeah. That's a better way to put it. Thank you, Joe. But still, 10 out of 16, that's quite a significant number of women in that time, considering, what did we say before? Was it 30 odd patients had died in that 1 year, 2006? Yeah, it was 2016 to 18. Do you remember? I think I'd said 31 women had died in that 3-year period. So it just goes to show that there has been a significant increase in terms of number of women who died. Of those 10, 7 died from COVID infection, 6 from cardiorespiratory complications, and 1 from thrombotic complications. Care, we all know this, the care that they received was extremely variable with minimal or delayed obstetric or midwifery input. So I think I kind of find that a bit surprising. When there's a pregnant woman, you find everyone else is generally quite nervous and they tend to ask for obstetric input quite quickly. But again, that's the whole reason for early escalation, getting the right people involved. I remember at the very early days of COVID, we weren't particularly good, even like giving steroids and then thinking about delivery. And I remember we had 1 or 2 really sick patients last year where it was delayed. And obviously we learnt lessons from that. So we tend to give steroids much earlier in these women, just in case they might deteriorate and need delivery sooner, so that it reduces obviously neonatal risks if baby's born preterm. Okay. Anything else about COVID? We are almost there. So flu's flu is always there, isn't it? A few years ago, there was a spike in flu cases, and so that was in 2009 gosh, the H1N1 flu pandemic. I don't know how many of you remembered that or not, but there was a significant increased risk of deaths relating to flu. And then there was this really big drive about flu vaccination since then. And the incidence of women dying as a result of flu has gone down dramatically. But again, it's again thinking about flu vaccination and encouraging women to have it. I'll be honest, I don't know what the recommendation is at the moment, whether or not they can have flu and COVID at the same time. I remember I did ask this in one of our governance meetings recently, and I think the pharmacist was going to come back to us, because it would make sense if they could have both in one go. But then again, you can understand how some women would be a bit apprehensive about having that. But I know our occupational health are happy for us as non-pregnant people to have both jabs together. What's happening in other units?
I know we've got the same thing with our occupational health people. They're aiming for us to have both done at the same time.
Yeah.
But I don't know again about the pregnant people.
No, that's right. But again, encourage your women when you see them in clinics and assessment units that they should have to have the flu vaccine. I guess it's how you use the words. Don't tell them you have to have it, but you know, strongly consider, recommend, or whatever it is. No one ever likes to be told what they can and can't do. And the good thing about this is that you could tell them that it can prevent flu in their babies for up to 6 months because of the transfer of maternal antibodies as well. So yes, this just summarises that. This was one of the recommendations at the time for the flu vaccination. The last few slides are again from the Embrace report, but it's looking at what were the general themes. And what's really sad about all these deaths, a lot of them are avoidable. But a lot of the themes that come out, they're the same kind of themes. And I've said this throughout. So delaying diagnosis, not finding a source, and not assessing the patient properly, not thinking of non-obstetric causes, and not getting a timely senior review or caring for the patient in the right place. So yes. This one relates to source control. So a patient who had an IUD in the late second trimester, she presented with a temperature, tachycardia, low blood pressure, was diagnosed to have a placental abruption, but sepsis wasn't considered initially, so she didn't have any antibiotics, didn't have the appropriate bloods, and source control was not initiated. And look at that, it was group A strep again. So this is the point. It's very easy to get sidetracked. And again, you can see how this could happen to any of us. Someone that comes in with an IUD, tachycardic hypotension, potentially, I don't know if she'd had any bleeding or not. The fact that she had temperature, though, I don't know. I would hope I would think about infection, think about sepsis, but again, you can appreciate how it's very easy to get sidetracked, because all of a sudden you think of abruption. What are the implications of abruption? Well, she's bleeding a lot because she's going to DIC and all the rest of it. So it's just trying to think about the wider picture, making sure that you've covered all bases. So that was the point of that case. So what Embrace say is, it's important to try and identify a source. But as I say, from day-to-day practice, think of all the, even gynae patients. How many patients do we have with a suspected abscess and things? How often do we actually identify a bug? So it is very difficult, but we should try our utmost best. Talk to the microbiologists earlier, sooner rather than later. You know, simple things. Don't forget about your vaginal swabs, your throat swabs. Think about imaging. Was it Joe, I think, who mentioned about imaging as well, being reluctant or not thinking about it, or even repeating your imaging? And I know you guys may not be calling the shots, so to speak, you know, when someone is really sick like this, but you might well make these suggestions and say, well, should we talk to a microbiologist? Do we need to think about doing another CT, perhaps doing another MRI? To see what, if anything's evolved, and you know, have we missed anything else? And reluctance to take surgical measures. So thinking that the patient's just going to get better with antibiotics. I mean, this happens a lot of the time with tubo-ovarian abscesses, which I know I am digressing, but I don't know how much experience you guys have had already as ST1. Some of you have ST2s in the gynae world, where you have a patient that's just sat on the ward with a suspected or a known tubo-ovarian abscess, not getting particularly better. But we know that they can be surgically very difficult to manage, especially if the bowel's involved. You can get bowel resection and all that kind of stuff and cause more morbidity. But sometimes you just need to take that step and do surgery. And sometimes if you don't, it can be too late and you can maybe lose the window of draining that collection or whatever it was. So another case about incomplete assessment. A patient started to feel unwell after a few days after a vaginal birth. She was admitted 4 days later with a raised pulse temperature, and she had a temperature during labour. She'd been discharged home with a borderline tachycardia as her Mal's score was only yellow. No observation were recorded at the postnatal checks when she reported that she felt unwell. The day after a second check, she contacted the health services and was reassured she had a tummy bug. A GP answer phone message indicated that home visits were only for those too ill to attend. Oh gosh, and she died for overwhelming group A strep. It's a horrible bug. What are your thoughts reading that case?
Really scary.
It is scary, isn't it? But this is us. This is what we're not doing it intentionally. But you can, I mean, I don't know how you can't act on certain parameters or not record parameters. So again, it's important thinking about your documentation and things like that. But you could see something like this, it shouldn't have happened. Do we all agree? Or we should try our best to prevent it. Now, I don't want you guys to be like really paranoid about every single patient, but I think sometimes these real life cases, they'd probably stick with you a bit better than trying to come up with pretend cases, because these are real women who unfortunately have died, and there's always so much learning. But the focus of this case was the fact that she was never completely assessed. So the recommendations out of this was that in the postnatal period, health professionals need to perform and record all the basics, basic observations, so their pulse, blood pressure, temperature, respiratory rate. Ideally, when someone's discharged from hospital, their obs should be normal. If they're not normal, then we need to, do everything, try our best to find out why they might have a raised pulse or whatever it is. I know we've had patients with a raised BMI, for example, and they're constantly tachycardic. And then as long as you've kind of ruled out XYZ, maybe you've done your echo and all the rest of it, sometimes you would just have to accept it's normal for that patient, but not just discharging them without having done all the full checks. The same applies for the midwives. Need to take and record all the basic assessments, including temperatures, and assess the woman as a whole, not just looking at a score on a piece of paper. I've got something here about TB. You guys can read this about TB. I wanted to just look at this last case, I think it is. Yes, last case, all doom and gloom. A woman in her third trimester went to ED with 1 week history of COVID symptoms. Her observations were put on a News chart, but not a Muse or Meows chart. She had a respiratory rate of 36, which was not recognised as significant. Her first review by a member of obstetric staff was 11 hours after she attended, when a junior obstetrician found no obstetric concerns. She deteriorated a few days later, was documented to need HDU or ITU care, but there were no beds available locally. Her care was discussed with the consultant obstetrician, who decided she needed a cesarean. Then afterwards, it was noted there were no beds, and she was transferred back to general ward, where she deteriorated. She was eventually intubated, transferred to ITU, but her condition worsened and she died a few days later. I mean, it's such a tragic case. I mean, there's so much in there. Why was she seen in ED in the first place? Well, obviously with COVID symptoms, that's fine to go to ED, but not to be seen by an obstetrician after 11 hours, respiratory rate of 36, it's screaming out to you. I don't know what you guys think, but there's so many opportunities where we could have done things better. What's everyone's thoughts?
Yeah, I mean, 36 is a big number.
Yeah, absolutely. So again, it just shows the importance. But then again, even if you're not pregnant, you've got a respiratory rate of 36. To my mind, that's still quite significant. And the other thing is, remember, this patient is not just a pregnant patient. She's still a person at the end of the day. So saying there's no obstetric concerns, great, but what about the rest of the patient? To look at the whole picture, look at the patient as a whole. And I think one of the other learnings, if I remember about this patient, is if there's nothing, if there's critical care can be initiated in a variety of settings, but if you can't manage her locally, then look around. Maybe you need to transfer her elsewhere. I mean, she might have been too sick for transfer and things, but I think in this case there was never any thought about that. And I know we had somebody that was very sick in gynae actually, and the team was excellent, and the registrar in particular was really good. And there was the patient was really sick, needed to go HD or ITU, but ended up on our gynae ward. But this registrar didn't accept it. They escalated it to the bed manager and to everyone else, the gynae consultant, everyone was involved. Talking to the surgeons, trying to liaise. Oh, that she needed to go to theatre. And then the backup plan was actually, if we can't get her into theatre here, we're just going to transfer her elsewhere. So it's just thinking about the bigger picture, thinking outside the box. But anyway, I digress. But a recommendation from this case, a consultant obstetrician should show clear leadership, be responsible for liaising with all other members of staff in the care of these women. Remember, it's not just about what you do in isolation. You all have to work together. If patients are on other wards, daily consultant input is essential. Signs of decompensation, so being aware of that. So, educating those who aren't familiar with obstetric patients is also really important. Last two slides, and then you guys can have a quick 10 minutes before the next session. So the last two slides just summarize learning from one of the CMAC reports, I think in, gosh, I don't know, at least 10 years ago. So it talks about thinking about sepsis at every stage in someone that's unwell, who's currently pregnant or recently delivered, thinking about timely recognition, fast administration of IV antibiotics, involvement of expert senior review at an early stage. If they keep going back to the GP or the community midwife, coming back to DAU or your obstetric unit, that's a red flag in itself. And then you should undertake a thorough assessment of the patient, make sure that we haven't missed anything. Seek advice from microbiologists early on, give antibiotics or change them if they're not responding. Have adequate critical care support for patients who become unwell. And it talks about flu vaccination. So this was, let's say, about 10 years ago. And then if we look at the recommendations of the most recent, one of the recent Embrace reports, it's quite sad because it's the same themes, it's the same recommendations time and time again. It's not like anything new is happening or anything particularly different is happening in these deaths. So the point is we're just not learning from these cases, because it still talks about prompt recognition and response, meaning that there's still a delay in diagnosis, so recognizing or escalating. Many lessons have been learned previously, but improvements in care may have changed the outcome in 68% of women. So at least 2/3 of these women, we could have prevented them from dying. So yes, it's all very somber. I am very sorry, but I think it's really important just because we think about sepsis, and but it's in the public eye a lot more. But I think we get a bit too complacent about it because we probably overdiagnose it in our patients, which is good. So we've got a lower threshold. Nearly every other patient goes on to antibiotics. But so I wonder if we're very good at then recognizing those women that do deteriorate more than your average patient. But you must think about sepsis. So that was why I didn't want to just talk about typical sepsis, but actually the whole implication of it for our patients. So that's any questions, comments, anything from anyone?